I want to be respectful of everyone's time.
Sure. All right, well, welcome everyone to the July 2022 Transformation Tuesday. My name is Michelle Arnaud. I'm Vice President of Gray Panthers NYC. Jack Kupferman, our president, is just back from a well-deserved 3-week vacation, and he asked me to make a few brief remarks. It's my great pleasure and honor to take his place and to see all these familiar faces and unfamiliar faces here. This is the lucky 13 Transformation Tuesday. It was last year at this time that I proposed to Jack that we launch the series following the success of our documentary, Honoring Nursing Home Lives Lost. And it's thanks to all of you here that we've built this space to address issues that touch all of us in the effort to institute positive change in nursing homes. You can find the recordings of our past programs on our YouTube channel, which we will put in the chat. And we now convene the last Tuesday of the month, so please circle August 30th at 2 p.m. for the next one. Of course, we have to determine what the subject will be, but there's always something to talk about. Gray Panthers NYC is so grateful to EmergingAging for partnering with us today and bringing together a panel of experts to address the topic that touches everybody, which is how to pay for long-term care beyond Medicaid. Today's program will be facilitated by Allison Cook, Chief Strategist of EmergingAging, as well as founder of Better Aging and Policy Consulting. So, as I said, please put your questions in the chat. We'll do our best to address them all and answer everybody. And now I will pass the mic to Allison, who will introduce our other guests. Thanks, Allison.
Thanks, Michelle. Hi, everyone. I'm Allison Cook. Michelle already introduced me, so I won't spend time on that, but I will just briefly provide an overview of EmergingAging for those who are not familiar with it. It is a networking group for emerging professionals in the field of aging, and this year is our 10th year, which is pretty exciting. If you would like to learn more about EmergingAging, and you're going to hear my dog in the background. If you'd like to learn more about EmergingAging, you can go to our website at www.emergingaging.com. You can sign up for our newsletters. You can hear about other exciting events that we put on and really build that connection within the field of aging. So without further ado, I want to jump into our presentations today. We are going to start off with Wendy Goidel, who is going to share a little bit of the current status of our payment system. How do we in the US pay for long-term care right now? Then I will provide an overview of some of the different models we can think about beyond Medicaid. Of course, my dog just starts barking as soon as I start speaking. And then we're going to sum it up with Veghte from the Walk Cares Fund, talking about some innovative work that is happening in Washington State. I would love for all of you to put questions in the chat, as Michelle said. I would also love for you to think about the lessons and learnings that we can pull out from the learnings and apply to our own states and communities. I also want to emphasize, I know that Transformation Tuesdays is about nursing homes, and how we pay for nursing home care impacts the care, the quality of care provided in nursing homes and how nursing homes are structured. So if we think about a way to properly fund the system, then we can also think about ways to improve quality and access and equity and all the other things we care about. Without further ado, I am going to pass it to Wendy. And again, if you have questions, put them in the chat. We will have time for Q&A at the end, and I'm going to mute myself. Go ahead, Wendy.
Can you see my screen, everybody?
Yes, we
Yes.
can.
Okay, great. Just checking. You won't hear my dog barking because I'm not allowed to bring her to the office, but unfortunately, no emotional support animals here. But I want to thank you, Allison, for the introduction, and to Emerging Aging and Grey Panthers, both NYC, for giving me this opportunity to participate this afternoon with all of you. As Allison said, I'm going to talk about what I see in my practice every day. We're in the trenches, witnessing the crisis in the long-term care delivery system and the financing of programs designed to provide necessary care to our clients. And the alarm bells have been ringing for decades, and advocacy organizations such as yours, legal and non-legal, have been clamoring for change. So in the next 15 minutes, I'm going to introduce you high-level overview to what long-term supports and services are, what our typical families and clients deal with on a daily basis, how long-term care is currently financed, and why the current Medicaid system is unsustainable. So long-term supports and services really refer to a broad range of clinical health and social services and supports required by individuals who lack the capacity for self-care due to either physical, cognitive, and/or mental disability or conditions. And these individuals often need assistance or supervision with several or all of either the activities of daily living, which we call ADLs on the left-hand side of the slide, all those activities that all of us do and take for granted on a daily basis, and also instrumental activities of daily living, which are really critical for allowing us to be able to reside as independently as possible, ideally in the community. But these services can be delivered either at home or in independent or assisted living communities and in skilled nursing facilities. There's no question that the aging demographic is growing and that people age 65 and up are expected to comprise the largest sector by 2034. In April 2020, 17.5% of the population in New York State were individuals in that age cohort, and 70% of older individuals will require long-term supports and services at some point in their lives, with 15% incurring significant expenses with costs exceeding $250,000. And against that, there's a frightening shortage of paid caregivers in the workforce at a time where millions of Americans require these types of services. And fewer people are entering the care workforce at a time when more people are leaving the industry for either higher paying and less stressful or demanding jobs. So the shortage of care coupled with this demographic creates a perfect storm. And I'm going to come back to this momentarily because I want to introduce you to typical clients of ours, Sam and Sally. Names changed, of course. They're a couple who have been married for 60 years. Sam is 85, Sally is 82. They reside in their co-op apartment in Queens, where they raise their two children, Leslie, a 55-year-old school teacher who lives in Brooklyn, and Robert, a 58-year-old engineer who resides in Michigan. After exhibiting some signs of short-term memory loss for years, Sam was diagnosed with dementia and now requires constant supervision and assistance with most of his activities of daily living and all of his instrumental activities of daily living. This is taking a huge toll on his wife, Sally, who, while being cognitively sharp, is physically frail, and she cannot provide Sam with hands-on care any longer. Well, Leslie can help her parents for a few hours on the weekends. She has a job, other commitments, and a family. And Robert, the out-of-town son, it's always the out-of-town son, right? He can offer some emotional support and some help during intermittent visits. But after considerable coaxing by Leslie and Robert, Sally hired an aide to help Sam for 25 hours a week at $25 per hour. But Sam's condition really requires 24/7 care. The family obviously is concerned about the costs. Other than their apartment worth about $750,000, they have about $250,000 in savings and retirement assets worth about $500,000. Their joint monthly income is $6,000 and their living expenses total $4,000 a month, leaving $2,000 for care. But at $25 an hour, Sam's needs, if he got all the care he needed, would cost $600 a day or $4,200 a week, or about $18,000 per month. So no wonder why the family is stressed out and frazzled. I mean, who wouldn't be? Their $250,000 worth of savings would be depleted in just about 14 months. That's simple math. That's why I can do it. And that's just for Sam's care. So what if Sally requires care in the future? How are they going to continue to reside in their home? So the family's stressed out, confused, second guessing some of the choices they made and choices they didn't make. And they're not sure how they should proceed and how they're going to pay for the care. And Leslie's trying to juggle all these balls in the air. I'm hoping she's not going to drop any of them. And she's really frustrated that her parents, despite all the urging, refuse to plan to protect their assets. But nevertheless, the family wants Sam to remain at home with care. And that's ideally what the ultimate goal is for all of us and for all of our clients, hopefully keeping them out of more restrictive care settings. And I know nursing homes are a big issue with you and with all of us, but we want to help to preserve the ability for older adults to safely age in place. So stay in the residence of their choice. That could be their home, their apartment, where they live, where they raise their children, where they downsize to. It could be an independent or an assisted living facility, but we want to keep them as independent as long as possible with the least restrictive environment, and hopefully without becoming destitute.
Wendy, excuse me, Wendy, sorry to interrupt you. Could you use the full presentation mode for the slides?
Oh,
Because we're seeing the next slide coming.
Oh,
so.
sure.
Yep, thank you.
Trying to, let me see, find the full view. I'm sorry. If anybody knows how to do that, please. I don't know if you can see the whole thing. I'm sorry if I figure out how to do that.
Take it out of presenter mode. That's probably what you're showing us.
What? Okay, I'm not sure how to do that without some assistance from my AV squad, which is dating me.
I think it's fine for today. I don't think it's
it's fine. Just continue.
Oh,
Sorry.
Okay, I apologize for that. Yeah, if normally I put it in slideshow view, but I'm not sure if I can do that without more assistance. So, well, obviously, from that example with Sam and Sally, you see how expensive care is, and no matter what type of care someone requires, whether it's home care, whether it's a day program, a social or medical model, whether it's assisted living or nursing facility, these are the average costs of care, both on a monthly and annualized basis. So depending upon an individual's financial situation and the magnitude of care that's required, it may not be affordable at all. So according to the US Census Bureau, the average median retirement income for individuals 65 and up is $47,357. And the Federal Reserve's 2019 survey of consumer finances reported that the median value of Americans' retirement accounts was only $65,000, and only 50% of families even had retirement accounts. And we all know that the cost of living varies greatly throughout the country, and many people find themselves in the unenviable position of needing to choose between paying for food, clothing, shelter, or all their basic necessities as opposed to care. And I don't know if anybody of you saw this just yesterday. Judith Graham's Navigating Aging column in yesterday's New York Times actually addressed this particular issue. So I guess timing is everything. Maybe she knew about this presentation. I don't know. But so funding care is typically very much a middle class problem. We see clients falling into three categories: those who have ample income or assets, high net worth. They can always opt to pay privately. They can self-insure, pay for it themselves. We have clients who have a lot of significant pension income, Social Security, interest and dividends, and other income rendering them ineligible for Medicaid benefits, which we'll talk about in a moment. Obviously, if you are poverty level or teetering around that, those have relatively easy access to the Medicaid program. They will be financially eligible. And the middle class gets squeezed. They have to deplete their assets or protect assets way in advance of needing care to financially qualify for the Medicaid program. And in all my years of practice, these are on the slide, the only funding sources that we could come up with for paying for long-term care. So there's a widespread but greatly erroneous belief that Medicare will pay for long-term care. And many people understandably use the terms Medicare and Medicaid interchangeably. Many of our clients do, but they are actually very different programs with different types of requirements. Medicare is a non-means tested program. Just going to skip here for a moment. It will pay for our medical and hospital coverage for individuals who are 65 up or those who are disabled. It will pay for 20 days in full after a 3-day hospital stay. It doesn't pay for ADL services at home or in assisted living. It will pay for days 21 to 100 with a copay, but there's no assurance or guarantee that will cover all of those 100 days. And after the coverage ends, other sources of funding need to be explored. And even though 2/3 of Medicare beneficiaries need assistance with their activities of daily living, Medicare doesn't cover those services, though, so they have to cover those costs privately. And about 25% of those beneficiaries spend 20% or more of their income on out-of-pocket health expenses and expenditures. So after Medicare, obviously, we talked about being able to privately pay. Long-term care insurance is another option. It's existed for decades, but there's a lot of confusion about what's covered. And the policies are largely affordable for most middle-class individuals. A lot of people can't afford to pay the premiums or don't want to pay the premiums, which are dictated by many different factors, including the ones on the slide. Many insurance companies withdrew from the market, and they don't even cover, universal coverage anymore, lifetime protection. So relatively few adults age 40 or older obtain these policies, and there's been a downward trend. You can tap into the equity in your home through conventional or reverse mortgage proceeds. There are some veterans aid and attendance benefits if you qualify for that, but it's not going to cover anywhere near all or a great portion of most of the care that individuals need. So then we get to the Medicaid program, which is a single largest payer source for long-term supports and services. And it's on this slide last because it is the payer of last resort. All other funding sources need to be explored and exhausted, the ones on this slide, before Medicaid can be considered. Medicaid is a federal, state, and local run program, which pays for all or a portion of the cost of care, either at home or in a skilled nursing facility, for either low-income individuals or those who establish medical and financial eligibility requirements. Every state's system is different. And the rules and regulations regarding financial eligibility are going to differ from state to state. While every state has and is required to provide institutional coverage, the home and community-based services are going to vary widely from state to state. And there are services which are covered, services which are not covered. They're all on these slides. I'm going to skip over these to save time, but it will not cover everything. That's why even if you are a Medicaid recipient, you still have to keep your Medicare coverage or other insurance coverage for hospitalization and medical expenses. We're really talking about Medicaid to cover either the cost of long-term care. And there are two main types of Medicaid that I'm going to introduce you to, and these are New York numbers, because obviously I practice in New York, and I think most of you are probably New York residents. And so these slides are just designed to give you a very high level overview of the stringent income and asset tests that exist for Medicaid financial eligibility. So for the community Medicaid program is the program that will pay for all or a portion of the cost of care in someone's home. There currently is no look back period. I'll get back to that in a moment. So we could basically transfer all of your excess assets out of your name today and get you eligible for community Medicaid as of August 1. Okay, but that is now. Okay, soon to be implemented will be a phase in of a 2.5 year or 30-month look back period. that was supposed to have been phased in over the last couple of years, but because of the public health emergency due to the coronavirus, this has been pushed off. Now we're told it's going to be phased in October 1st of this year. However, chances are that it might get pushed back to 2023, in which case now there will be a phase in of a 30-month look back period. So if it starts in October 1, it'll go back a look back period to October of 2020. So really important to note that in terms of planning. But these are the financial.
Just want to say 1 minute warning.
Oh, that's it. Okay, financial eligibility, income and assets, very stringent income and asset tests. Chronic institutional Medicaid. These are the numbers. So these numbers don't lie. These are the actual numbers. Medicaid's going to look at your income and assets from all sources and determining that eligibility during the look back periods. And then it's just designed to show you how much money is being spent currently in the Medicaid program, $661.5 billion. So these numbers don't lie. Most of the spending is attributable to the elderly and persons with disabilities, and these numbers are growing, and there's going to be an average annual growth of 5.6% is expected for spending up until 2030. So the present system of financing is broken, it's unsustainable. The hurdles which people need to jump through to obtain financial eligibility from Medicaid is really unfair. And while the program pays for all or a portion of the cost of care, there is no guarantee that anybody's going to get all the coverage they need, and it doesn't ensure access to quality supports and services. And the changes upcoming to the program is just going to create more barriers, and probably the changes to the community Medicaid program are probably designed to force more people into skilled nursing facilities, which really makes very little sense and it defies logic, and it's really a violation of the Olmstead decision. It's a landmark Supreme Court case that says that people with disabilities deserve to live in the community in the least restrictive environment if it's safe and appropriate. So these are all some of the fundamental flaws of the program, and the adverse consequences or unintended consequences that people face, again, is the inability to pay for all of their living expenses plus the cost of care, causing them to incur massive credit card debt, making choices that are unpalatable, skipping meals, delaying necessary care, living sometimes, even if they have some care, unsupervised for the hours that are not granted to them. So, and if they have the inability to fund and the supplemental care that they need, sometimes like Sally might be impoverished paying for Sam's care and the magnitude of care that he needs. Leslie and Robert's inheritances may be eliminated. I don't think they're not going to be very happy if their parents spend down all the money. And all the unquantifiable personal and family costs that are just incredible and hard to, in terms of stress, anxiety, burden on the family members, loss of time from work, missed opportunities, leisure time. I know somebody just said they went on a 3-week vacation. If you're a family caregiver, that's not happening. So there's a lot of issues, and the toll that it takes on families is incredible. So that's where Allison and Dan they're going to come in, and they're going to talk about all these other options. Got to think outside the box creatively for other potential financing sources and ways to fund care so people can ideally stay at home and out of skilled nursing facilities. So I think that's where I'll end and segue over to Allison for that.
Thank you, Wendy. Thank you. And I forgot to mention earlier that the slides will be made available after today's presentation. Wendy included a lot of information in her slides so that everyone will have access to them. If you don't mind, Wendy, just stopping sharing and I can share my presentation. Continue, please, to put, I see 1 or 2 questions in the chat already. Please continue to put questions in the chat. We are going to get to them during the Q&A session at the end of today's presentation. So let's see, can you see my slides?
Yes.
Yes, okay, great. So I'm going to be talking about LTSS financing models. while this might sound a little bit like a policy wonk topic, which it is, I'm going to start by talking a little bit about why we should care about the financing models. As Wendy very well explained through the story she shared, our LTSS system impacts everyone. It impacts consumers that include older adults and people with disabilities. It impacts family caregivers. It impacts workers who we quite honestly do not value enough and do not pay enough. And therefore it impacts all of us. Also, our system exacerbates existing inequities in our society. Generational wealth is the primary contributor to wealth in our country. And by structuring a system that only has Medicaid that requires people to get rid of those assets and prevents the accumulation of generational wealth, we have a growing gap between the wealthy and everyone else. There's also growing demand with the aging of our society and with the improved medical care that allows older adults and people with disabilities to live longer. And then finally, financing impacts how we deliver care, how we provide services, and therefore impacts the quality of care and quality of life of people within the LTSS system. The way that we build the system determines how much we can invest in the workforce, determines what settings we provide care in, it determines how we measure quality. So it's incredibly important to think about how we structure a financing system. And as Wendy explained, it's important to think about what we can do beyond Medicaid. I am going to talk about 4 financing models, and I'm also going to talk about their impact on equity. I would like to mention that you can learn more about what I'm sharing about in a series of 3 reports that I did with MIT CoLab. They are running a fellowship called the Mel King Fellowship that's focused on LTSS financing. You can also learn more about that fellowship at hopefully a link. I can't quite see the chat while I'm in presentation mode. A link that's hopefully in the chat that will be to 3 reports on this topic, as well as to MIT CoLab's program. So these 4 models are useful to really think about what's possible, what the options are out there, but it's also important to note that they're not mutually exclusive. We could have combinations of models and we could have hybrids of models. I'm going to talk about each of them in more detail, so don't worry about writing down any of these. I will also be sharing my slides. Again, put questions in the chat as we go along. The first model is the safety net model. This is where the government provides LTSS coverage to those who fall below a certain income and asset amount. In the US, this is the Medicaid program. I say that it has a variable impact on equity because it is incredibly important and ensures that those who fall below that income and asset amount can access the services they need. But as Wendy explained, there's that gap between where the eligibility starts and where you're truly able to pay for the long-term care you need. So not all that can't afford long-term care are eligible for Medicaid in the US. The second model is private insurance, private LTSS insurance. This is also a model that we are familiar with in the US. I did see a question about it in the chat. We have not had large-scale enrollment in these private plans, largely because of the cost of insurance premiums and a lack of education around the need for insurance. In the US, the size of the monthly premiums to be able to get long-term care insurance means that mostly only the upper middle class and the wealthy can truly afford it. And those are mostly the people who may have been able to afford long-term care out of pocket. So it hasn't had very much impact on equity within our country. The third model is social insurance. We have not had quite as many LTSS examples in the US, but we do use social insurance, for example, for our Social Security system. It's where those who pay into a government-run program are eligible for benefits when they meet the qualification levels. Often we talk about this as a payroll tax that then makes you eligible for benefits down the road. I say that this has moderate to high impact on equity because it depends on some of the specifics of how the program is structured. It does by saying that people who, by putting it as a payroll tax, everyone who pays that tax is now eligible when they meet certain qualification limits. So a much broader group of people than, for example, with private long-term care insurance are eligible for a program like this. The limitation is that sometimes these programs have limits in terms of length of time that a benefit could be provided or a dollar amount that a benefit could be provided. And that means it's often not as good of a fit for people with disabilities that may have longer term needs and those who haven't paid in for a long enough time, such as retirees or those near retirement. The Walk Harris Fund that Ben is going to talk about momentarily is an exciting example of this and the only example of a social insurance LTSS program in the US. I will not steal his thunder, so I'm not going to get into that, but I will mention that there was the Class Act that was a part of the Affordable Care Act that would have been a federal social insurance LTSS program. It was one of the only parts of the Affordable Care Act that was repealed because the way that it was structured made it not financially sustainable. So structuring it properly is very important. The fourth model is universal coverage. This is where everyone receives LTSS coverage through a government-run program. When I say everyone, I'm exaggerating a little bit. Usually there's some sort of limitation, but just about everyone. It has high impact on equity because so many people are eligible, but the limitation is that it is very expensive to run. You can structure it to only cover home and community-based services or only cover institutional services, so nursing homes. But either way, the government has to make sure that there's enough income coming in through taxes, typically, that can go towards this coverage and has to allocate enough money every year to cover this cost. That is very different than a social insurance program that tends to have that built-in financial sustainability through a payroll tax or other formats. In the US, we do not have any examples of universal LTSS coverage, but there are some other countries, especially Scandinavian countries such as Sweden, that utilize this universal coverage model. And the third report in that series of reports looks at some international models, including Sweden. I don't want to take up too much time. I'm already a little over, so I'm going to briefly say a few other quick points, which is that many other developed countries have more supportive LTSS programs than we do. We can learn some things from them and see what might be applicable in the US or in our state. Implementation of any program increases equity. When we implemented Medicaid, we increased equity. But that's not enough. We need to implement more because of that gap that Wendy explained. As I said at the beginning, we can also explore combinations or hybrids of these four models. So social insurance supplemented by private insurance or supplemented by a safety net program that maybe has a buy-in component for people who are above that limit. And then finally, we need that broad base of enrollment. We need a lot of people to enroll for a program to be sustainable and for it to be more predictable. So we would at least need it to be at a state level or a federal level, but we haven't seen much federal movement lately. So key takeaways, and then I'll stop talking. One, the US can and must do better. Our current system is not sustainable, and we need to figure out something that works, especially as the demands on our LTSS system are increasing. Two, these are the things I'm hoping you'll remember from all of this information I'm throwing at you. Two, in absence of federal movement, states can and should innovate. That's why we're so excited to have Ben speaking next. And then three, we have examples of models and programs, both in the US and outside of the US, that we can learn from. And then the last one I'll just say before concluding is that hopefully through today's presentation, you'll learn a little bit about what the options are out there, and you can start having the conversations in your own communities about what's possible, because we are not going to create change. We are going to continue with the status quo unless we come together and push for action. You can see my contact information here. I'll probably put in the chat in a moment. But with that, I want to turn it over to Ben so he can have enough time to share about what's happening in Washington. And then we can have some time for Q&A.
Great. Thank you so much, Allison. And I'm not going to use slides. I'm just going to present without them, and I'll try to keep it brief so that we have time, plenty of time for Q&A. So my name is Ben Veghte. I'm director of the Walk Heroes Fund in Washington State, which is the nation's first a universal social insurance program for long-term care. It works similarly to programs in Germany and the Netherlands and Japan, South Korea, other countries which have had this for a long time. The way that we're paying, as the other speakers have mentioned, the way that we're paying for long-term care currently doesn't work. It works well for people who are wealthy, who can afford private long-term care insurance or pay out of pocket, but it doesn't really work for anyone else. Medicaid is available for people with very low income and assets, but there are problems with access to Medicaid, as the other speakers highlighted. And also, no one's plan for retirement, no one's utopia for retirement is to become impoverished and have to apply for a government program where you have to show that you have low income and assets. And so the current system is indeed broken. This affects not only the people who need care, it also affects family caregivers. In our state, in Washington, which is a state of about a little over 7 million people, we have almost 1 million family caregivers. We have 860,000 family caregivers, about 11% of the population. And those people are impacted in multiple ways. The 61% report that the caregiving responsibilities impacted their job. 53% say they've gone into work late, left early, or took time off to provide care. 25% have seen their own health worsen since taking on the role. And there are financial implications as well, significant ones. Almost half of family caregivers report a related financial setback. On average, family caregivers spend about a quarter of their income on the people that they're caring for, their loved ones. And if you leave the workforce at age 50 or older to care for an older family member, a MetLife study showed that you lose on average $303,000 in lifetime earnings and retirement benefits, both from lost earnings for yourself and your lost 401k contributions and your lost Social Security benefits because you weren't contributing to Social Security during those years. You got zeros, and your Social Security is a product of your top 35 earnings years. So for every year that you have a zero or a low number, it lowers your average lifetime earnings, which in turn lowers your Social Security benefits. So there's the impact. It's important that we don't forget family caregivers in this calculation. So Walk Cares is a universal long-term care program. It's an earned benefit. It's like Social Security or Medicare. You pay into it. And if you pay into it, you have a right to benefits. It's self-funded from worker contributions. So what that does is means it takes you out of the annual appropriation battles in state legislatures. So a lot of social programs suffer from the fact that if a party comes into power that opposes the program, they'll cut the program or undermine it. We saw that with the Affordable Care Act. We've seen that with a number of we've seen it with as the AFTC turned into TANF. And TANF expenditures didn't go up at all during the Great Recession, even though number of people who needed social assistance, probably doubled. And so TANF was just a shadow of its former self. Social assistance in the United States is a shadow of what it used to be or should be. The point being that when you have a program that's a social insurance program where everyone pays in, then the broad middle class has a claim to those benefits and will politically fight to support retaining those benefits. And the higher income people will as well. You see that with Medicare and Social Security. Those programs don't get cut. In fact, they get expanded significantly over time because politically powerful people are paying into those programs and also expecting benefits from them. And those are the people who have the ear of lawmakers often. And so that's an important political lesson from a social insurance program versus trying to do it out of general revenues. You only pay in while you're working. So to walk cares or any social insurance program. So if you are laid off, like during a pandemic and you're unemployed, you don't owe anything into walk cares. Or if you take time off to raise a child, you don't owe anything during those years. Or if your income, if you're a very low income, you owe a lot less than if you're higher income. The contribution or the premium scales with your income. The premium is about 0.5% of wages. It's 0.58% of wages. So for the typical worker who makes $52,000 a year in Washington State, they owe about $24 a month or about $300 a year into walk cares. The benefit is $36,500. That's a lifetime benefit. It's a modest benefit for a modest premium. It's a start. It's not a highly generous program, but it's a significant benefit for people. Pays for about a year of home care for most people, which is, about a third of people need a year or less of long-term care. A third of people who need long-term care need it for a year or less. Another third need it from 1 to 3 years, and another third need it for 3 or more years. So for a third of people, this could satisfy all their need. And for the rest, it could satisfy a significant part of their needs, so that it also gives you time to plan and come up with a plan. Maybe loved ones can help out some of the time to extend that benefit over a longer period. But at least people have money to start with to deal with this, which is often a crisis in a family. And of course, over time, Social Security was a very small program initially, expanded significantly over decades. If walk cares is successful, it could get expanded over time. And another state like New York could choose to make the premium and the benefit much higher if they wanted to. Both the contribution level and the benefits are completely scalable depending on the political will in a state. So the benefit is also very flexible. Essentially, what we do is give people a budget to spend on their long-term care needs, a $36,500 budget, which goes up with inflation. And beneficiaries can choose to either hire a home care aide if they want a professional or if they need a professional, or they could also make a loved one a paid caregiver, which is a great feature because oftentimes when people need long-term care, the whole family is struggling financially. And being able to pay a loved one, whether it's your spouse or your child, to care for you using your walk cares benefits is a great feature because it keeps the money in the house and helps everyone pay the bills. You can also go to an assisted living facility or a nursing home. You can also get meal delivery, get a respite for family caregivers, as was mentioned earlier. It's often a big problem that people can't get time away. You can also put grab bars in the bathroom. Pretty much anything that's long-term care you can do with your benefits. And I'll stop there to leave plenty of time for questions.
Thank you so much. So just to summarize what we discussed, Wendy shared how our current system operates is very complicated and leaves out a significant chunk of people. I shared some models we can think about in terms of kind of high level, what might work, and then shared a specific example from Washington State of a social insurance program that will, for the first time, it's the first social insurance program in the U.S. that will provide an LTSS benefit, and it's very flexible. So I am going to just take a look at the chat.
There's a question from Kate. What about services that provide for nutrition or fitness?
Okay, I think that's a question for Ben.
Sure. Meal delivery is definitely covered, but better general fitness, no, that's typically not. I mean, we're going to pay for things that are long-term care. Typically things that Medicaid long-term care pays for, we would also pay for. But like gym memberships or something like that, or personal trainers, we couldn't. We don't do health care, but we do, what's traditional long-term care.
Thank you. And I see we had a question from Bob earlier. What is the status of long-term care policies? My sense is the insurance industry has pulled back and there's not great benefit value for premiums. I think that's a question for Wendy.
Sure. Well, a lot of the carriers got out of the business. So a lot of the traditional straight long-term care policies are not sold as much. There are a lot of hybrid policies now that are much more attractive, where it's a life insurance policy with a long-term care rider on it. So if you never use the long-term care benefit and you pass away, your beneficiaries will get the death benefit. So there's a pool of funds that can be used for either, could be all drained for all long-term care or partially long-term care and a death benefit, or it all becomes a death benefit. So it's much more palatable for individuals. That becomes more affordable, but typically it's not going to cover all of the, all of the care that's required. But you really have to work with a good long-term care insurance professional to really look at all the options out there and analyze your income, your assets, and how much coverage you need. And then, the premiums are dictated by a lot of different factors, and those factors are included: age, health, whatnot, are on the slide, one of the slides in my presentation.
I'm just going to pause. If there's anyone who either is on a phone and can't type in the chat, or has difficulty typing in the chat, I also want to make sure that you have the opportunity to ask questions. So please unmute yourself if you do have a quick question.
There's some more questions for Ben here.
Yes, I'm just trying to give opportunity for people who may not be able to use the chat. Okay. Well, feel free to unmute yourself at any point if you have difficulty using the chat. And go ahead, Michelle, you can ask the question.
Amy wants to know, Ben, can you speak about the political process to implement your program? Did it start as a grassroots effort or the opposite?
Good question. I think combination, but I'd probably say less grassroots and more SEIU 775 was a key driver. The state itself was aware. Washington State's pretty sophisticated in terms of its social policy and pretty far-sighted. We have some good Scandinavian ancestry here, and so people, as Allison, kind of implied, that Scandinavians are the best in the world at long-term care policy. So there was a joint legislative executive committee that was formed back in 2014 to look at the issue of how are we going to deal with the long-term care costs of the age wave. And so the state was aware of this, but at the same time, SEIU was pushing hard for a better financing model. ARP supported this as well. One of the things that I've been working hard on, and my team has been working very hard on the last couple of years, is making sure that the whole state is aware of all of the need for long-term care, the fact that they're not prepared for it, and to build support for the program. One of the problems we had initially is that, and this answers some of the other questions in the chat as well, is that there was one design flaw in our program, which is that it was a private insurance opt-out that was prospective. So it'd be one thing to say, if you already have private insurance, you would be able to be exempt from the new program. But even Medicare didn't do that in 1965. That was universal, as was Social Security. There were no opt-outs there. But they also, not only did they have that in there, but they also had in there that if you bought private insurance in the future, you could opt out. And that was a big mistake. And I would really strongly recommend any other state who wants to go down this road not to include that. Because what that did was create an incentive for the private insurance industry to go around the entire state to people that we hadn't reached out to yet, who hadn't heard about the program yet, to make presentations at all of their employers, and also reach out to them individually if they had a financial advisor or an insurance advisor or a broker, to tell them that product X is terrible because they want to sell product Y. So it's a very simplistic sales incentive, whatever. If I'm selling houses, I'm going to say the house next door is terrible because I'm trying to sell my house. My house is better than the house next door. We created that incentive for everyone who has a profit interest in selling insurance. And so people across the state were exposed to a multi-million-dollar sales campaign telling them What Cares is bad because private insurance is good, buy private insurance. And we then had to play catch up after that to reach out to all those people, and we're doing that now, to try to make sure they're aware, get actual objective information about what our program is, what private insurance is, and to make their own decisions. But really, a program like What Cares or Medicare, for example, or unemployment insurance or workers' comp, these are all social insurance programs. They can't be voluntary. As Allison mentioned, if you have a voluntary social insurance program, which is what the Class Act was, it will fail. Because in order for a social insurance program to work, everybody has to pay in: rich, middle class, poor, sick, healthy, old, young. If you have a voluntary program, which is what you have when you have a private insurance opt-out, it makes it voluntary. Then you get sicker, lower income people in the public program, and you get rich people doing their own approach to it. And that means that you have a more expensive risk pool to insure, which means premiums have to be higher. And you also undermine public support because you've exposed the entire state to negative public relations campaign, sales campaign. So all of those are lessons, I would say, from What Cares. If that's really the only thing that has been a big problem. I guess one other thing has been portability of benefits, and that's something we're working on now. We need to find a way to make it possible for people to use their benefits in other states if they leave our state. But we're working on this year. That's something that's easily solvable. And so there really is no reason why What Cares can't succeed or will succeed. It's pretty simple, really. It's Medicare has worked pretty well over the since 1965, right? It's proven model in 10 other countries, social insurance for long-term care. It's not rocket science. It's just like what we do for Medicare, for example.
Thank you. And I think that's really helpful as people are thinking about what might work in New York and other states. I see Jack has a really great question here about what is the relation to family leave expansion? I'm going to start, and then I'll give Ben a chance to add anything else. I think that's a really important question. We can't think about our various programs in a silo. The way that people experience them are all intertwined. You can't just think about Medicaid when Medicare is a part of the equation, and that's how I think about family leave. Our system is built upon family caregivers participating in their loved one's care, and in many instances, that is the preferred. It is preferred for a family caregiver to be involved in care. So we need to have not only a program that allows us to access the services we need when we need them, but also that supports the family caregivers in their role within our system. And so paid family and medical leave allows people to have paid time off to care for themselves or a loved one, whether it is a child, a loved one with a disability, an older adult, spouse. And so having a paid family leave program, I believe, is incredibly important. And we've seen that play out in some other countries as well. Ben, I'll let you add anything that you might want to.
I would agree with all that. I think that's important. I think in the United States, because the way our labor market and our economy work, there isn't as much scope for like really generous paid leave the way you have people are considering in some European countries now, like 3 years of paid leave to care for an older adult with half of your wages replaced. Like that wouldn't work in our economy. And that's a long discussion that there's not time for. But I think long-term care is expensive, and there's no substitute for a financing system that pumps a lot of money into long-term care. Family members can do some. You can be away from your job for a month or two or three, maybe. or maybe even 6, who knows? But most people need care for longer than that. And so, and even if you can't get away from work for that time, some people are able to carry a 300-pound, mom or dad into the shower and so forth. Some people aren't even physically capable of doing it, even if they want to do it, right? And so there's a role for professionals in this field as well, and that just requires money. And so I think it's really important to have a model that pumps money into this. Like you need, in a big state like New York, you're going to need, billions of dollars a year added to the system in order to be able to increase access.
Okay, so we have a couple of questions coming in. I'm going to try to get to them quickly. I don't want to run too much over time. Amy asked a question, and I want to clarify here. When I was speaking earlier, I was saying that other countries have universal coverage programs, and those tend to be more expensive. Social insurance, it depends on how you structure it, but those have a dedicated funding source that makes it a little bit more sustainable. And our private insurance program is very expensive to operate and doesn't work for a majority of our population. So yes, very true. I think that this question here from Shannon about how can direct practitioners help advocate for older adults in New York State? Is there a specific action coming up that we can encourage people to get involved in? That's a great question. I will say there is supposedly at some point in the near future a long-term care task force at the state level. So making sure that you work with groups in your community to make sure your recommendations are heard in that task force. The governor did say earlier this year that she would sign an executive action to create a master plan on aging. This is a process that has happened in California, and really it would allow a wide group of stakeholders to come together and say, this is what we need for our society as we age. Long-term care financing should be a part of that. That executive action has not been signed yet, but maybe pressing the governor to make sure that happens. And when it does happen, making sure that your voice is heard. And I'm going to open it up to others if you want to unmute yourself or put in the chat ways that people can get involved.
There's a question from Carol. Can someone speak to the nursing home transition and diversion program?
That's a Medicaid waiver program that we have a number of clients in that program where that program will pay for more care than what the more traditional community, the home and community-based services program will cover. A lot of individuals who have dementia, for example, and need constant supervision with all of their activities of daily living, basically. They can't live unsupervised, even if, so that does actually provide more care. So you have to go the traditional Medicaid route and then apply for the waiver. I mean, it takes a while. It could take 6 months to a year to get it, but if it works, it will provide continuous care. So it's very valuable.
I will just say Wendy's expertise in helping navigate our current very complicated system is always invaluable. Ben, there's one, I think we'll do one last question, maybe, and then we can wrap up. So there's a question from Joan in the chat. If the program is not voluntary and is required, why do you have to educate people to join?
Great question. Well, so initially in our initial statute, it wasn't voluntary, but it was, you could opt out if you bought private insurance. So a lot of upper middle class people and rich people were being marketed to directly by private insurers, trying to sell them something as a tax avoidance strategy. And so that's why we had to do, that's one reason why we had to do that outreach, was to make sure people had good information before they made that decision. But even beyond that, because we live in a democracy, if people aren't aware of what they're paying into and they're required to pay into something they're not aware why, then they're going to turn against the program and tell their legislators to cut the program or get rid of it. So if you don't bring the people along from the very beginning, it makes it much harder to implement.
And I think that's a really,
acknowledge two state senators who are attending today with representatives. Tali Beckwith-Cohen from Senator Brooks' office from Rochester. Thank you so much for staying the entire hour and the Q&A session. And also thank you to Hannah Kirk from Senator Elijah Reichlin-Melnick's office. I was very grateful.
thank you. And we don't want to take too much of people's time. I know we're already over, but I do want to emphasize what Ben said about creating an advocacy strategy that passes a law and goes through the implementation so that we successfully implement a new program. That's very important, and that's something that that we've heard over and over in the field as being important. So I'm going to wrap up quickly. Thank you all for attending today. In the chat, we just put the links to EmergingAging's website and the Gray Panthers website if you want to learn more about either of our organizations. I hope that you took away some very interesting ideas about what is possible, and you can start having conversations within your own communities about what you want it to look like in your state. What program beyond Medicaid could work? There was information in the chat with Wendy's contact information, my contact information, and Ben's contact information. And we hope to continue this conversation going forward. Michelle, did you have any final words?
Thank you so much, Allison, Ben, and Wendy for today's panel. And we look forward to seeing everybody next month, August 30th. We'll resume the conversation, and everybody please think on this topic, and let's work together to see what we can do to reform this important part of our society, which affects all of us. So thanks, everybody.
Thank you.
Thank you, everyone.
Thank you. Bye-bye.